treatment. We have discussed PDE5 inhibitors, we have discussed intracavernosa injections and some alternative kind of medicine like arginine, papaverine. So a little bit about surgery for people who have had failure with all these. Whatever, we of course we know later in urologic surgery for erectile dysfunction. So we are hearing from the horse's mouth.
In fact, somebody asked a question even during the tea break, and I was also asked if I want tea or coffee. So teaching sessions I have tea, otherwise I have coffee. Just because it's a pun. So the question is that what do you do if tablets don't work, injections don't work? There is something called a vacuum erection device. Not very effective, but basically it's a cylinder that is placed on the penis. You activate a pump, it will suck the air out of the cylinder. So it creates a vacuum around the penis. That then draws blood into the penis. And then you slip a ring onto the base and that holds it erect. Little cumbersome, but in couples who are in a stable relationship, too old or not interested in surgery, or diabetes which is not getting controlled, getting some erection but not enough, sometimes they find that this device is sufficient. It gives that little extra 20-30% so that they can enjoy sex. So that is one option. Otherwise, the final cure is a penile prosthesis implant. And it sounds like a bad joke. You tell somebody, oh, you can't get an erection, we're going to stick a piece of silicone into your penis and that will make it erect enough for intercourse. But in actual fact, that is the most successful form of therapy for ED. The highest compliance, the highest patient satisfaction rates are recorded with the implant. So what is this implant? There are two types of penile implants. Non-inflatable and inflatable. The non-inflatable is a silicone rod of constant length, constant diameter, fixed rigidity. So when that is placed in the penis through a small incision in the scrotum at the base of the penis, a small cut this size, through that you make a tunnel and place the rod permanently inside the two corpora cavernosa. When you put it in the penis, will then be permanently erect. So then how does the patient wear clothes? So there are two types of non-inflatable implants. In one, the front is stiff, but the base has a hinge. So at the hinge, the penis can be bent down or up with the underwear. And the penis is long, it is strong, but it is bent down. And when the patient takes off the underwear, it comes up partly, and he just holds the base to support the hinge. And then the penis can be erect, the rigidity is good, and he can have sex. The second type has a steel wire inside. So because of the wire, it is malleable. When you bend it, it stays bent and remains like that. And when he wants sex, he has to unbend it and it becomes straight. So both of these work quite well. The advantage is that they are simple. There is no mechanical failure. The patient just has to straighten the penis or support the base and he's ready for sex. The second type is the inflatable, where the cylinders are soft like a balloon. So the penis looks normal. Both the cylinders are in the penis and there's a tube that connects it to a pump which is also in the body between the two testes in the scrotum. And when the patient wants an erection, through the skin he feels the pump and squeezes it. And the pump transfers fluid into the cylinders, which then fill up like a normal erection, and the penis becomes strong and erect. And then he has sex, and when he finishes, he presses a button in the pump, the fluid flows back and it goes down. The obvious advantage here is it's more cosmetic, more physiological. The penis is becoming erect, it is expanding, elongating, becoming hard, and then becoming soft again. Disadvantage is it needs a little bit of training on operating the pump, but the major disadvantage is the cost. The non-inflatable, there is an Indian one that actually carries my name, and that costs 25,000 rupees. Then the non-inflatable with the steel wire, it is imported, and that costs 1.25 to 1.5 lakhs. The inflatable one with the pump, the implant alone costs 7.5 lakhs. Then the cost of surgery, etc., over and above.
And these are implants which stay for life?
So the non-inflatables more or less stay for life. Though occasionally they're fractured and had to be replaced, but generally they stay for life because there's no mechanical component. The inflatable one is a more complex device and can get spoiled. I have patients where I've had to replace it after 3 years, but I also have patients who have the implant since 15 years and are still going strong. Some of the companies give a 5-year warranty on the inflatable implant. One new company called Rigicon, which has just come in, they offer a lifetime warranty. So as and when it gets spoiled, which it will at some point, it can be replaced.
How many such surgeries would you do in a month, year?
Oh, quite a lot. Now we've been doing my implant, the Shah implant has completed 25 years.
And how many implants?
We lost count at some point. So every month we'd be doing at least 3-4 different kinds. The majority are the non-inflatable because it's very affordable. One of my student trainees now is assistant professor at Nair. So poor patients can get the implant free of charge. Or they just pay for the implant. And others we operate at Leelavati. And there also it's not too expensive. If you're using the Indian implant, in a common ward the total bill will come to 1 lakh, all inclusive. More of course in private rooms. But with the inflatable, the bill will go to over 10 lakhs. Luckily the cardiologists charge so much for the stents that our patients don't think of it as too much. Indication is when nothing else works.
Failure of other therapies.
So can it be put in diabetics? Yes, provided the HbA1c is below 7.5. Will a man experience orgasm after the implant? Yes. Can he father children? Oh, certainly, many of them have. Is there an age limit to which you can put the implant? The oldest man I've implanted was 82. He was a tea plantation owner, so all the time in the world. He had already been implanted 15 years ago at Mayo Clinic with an inflatable which had then failed. So he had actually come to me for a replacement of it. The youngest we've implanted is 22 years old, fractured pelvis accident, erectile dysfunction, not yet married, and post-implant has got married.
Such a boom, yeah.
So there's a wide range.
Sir,
The last question that patients have is, will the partner have satisfaction? Actually, perhaps more than what the average person would get, because it remains erect as long as you want it.
But even after ejaculation, it doesn't go
Even
down.
after. So if somebody has premature ejaculation, he could still continue thrusting, because with the implant the penis will remain erect.
So intumescence, does it create intumescence?
Little louder.
Does it actually create the sensation of intumescence?
Okay, so does it create a sensation of tumescence? Very good question. When you put the non-inflatable, the diameter is fixed, the length is fixed. However, the erectile tissue is still preserved around it. So depending on the pre-op, because we are doing this in patients with severe ED, some of them have no erectile ability in any case. Because some of them are younger men who have venous leak, where there is good inflow, but the blood is all flowing out. They may have tumescence over and above the non-inflatable implant. So in one of these studies that my resident did, 60% of men had good residual tumescence, and they are the ones who are really happy after the implant. Because the implant is giving good stiffness and the residual tumescence makes them feel more normal. With the inflatable, because it is expanding and filling up, the sense of natural erection is better. And many of them will also pump it up only partially, and then they will have some natural tumescence over and above. Some men will not have much tumescence in the penis, but they may still get tumescence in the glands if they have that capacity pre-op, because the implant goes only in the corpora cavernosa. The glans penis sits as a separate cap on top of the corpora. But it can also be a problem. Men who have no blood flow, with the implant they will have a good erection, but the glands will continue to remain flabby, and sometimes that is a complaint. So all these little things have to be fine-tuned in the pre-op counseling.
Any complications which are intra-op, which are bothersome?
The technical complications of surgery, but now after 30 years, if you ask me, I'll say that there's no surgical complication we can't take care of. The only real concern we have is infection. And the risk of infection in a normal population is about 2%, so 2 in 100. In a diabetic, I don't operate if they're not well controlled. If they're well controlled, it's 3 in 100. So the risk of infection is there, but low. If there is infection, then sometimes it settles down with antibiotics, but otherwise we have to remove the implant and then put in a fresh one.
Sir, Mediclaim would be covered it, no?
Unfortunately, Mediclaim thinks of it as plastic surgery and doesn't cover it. So it's unfortunate. Surgery for Peyronie's disease, where the penis is curved and we straighten it, penile implant surgery, none of those get covered by insurance.
So what is entity called fracture penis?
Fractured penis is a real entity. It sounds like a joke, but it's very real, in which the penis, when fully erect, if bent suddenly, the tunica albuginea ruptures and tears, and that is fractured penis. So it's a good question, because this will be a medical emergency where the patient may contact you. If he says, I was having sex and suddenly I heard a snapping sound, I lost the erection and there was swelling, that's a medical emergency, needs to be seen by a doctor immediately. Or sometimes they will say, I was masturbating and I forcibly bent it. And some of the men have told me that I had a spontaneous erection at night and I was embarrassed and I tried to push it down, and then I had this snapping and there was swelling. So if the patient comes early enough, the best treatment is to pull back the skin, expose the tear and suture it up, and that gives a perfect cure. Many patients present late, in which case we may conserve them. Most of them will do well on conservation, but sometimes the fibrosis causes curvature due to the fracture. So it is a real entity and it is a semi-emergency. What is a desperate emergency is priapism, which we were talking about earlier. If a patient contacts you and says, Doc, my penis has been erect for the last 6 hours, do not give him an analgesic and tell him wait till tomorrow. This is an emergency. He has to rush immediately to the casualty of some hospital or the other. Because if we treat a prolonged erection within 24 hours, we can always save erectile function. If they go beyond 24 hours, then it varies. Beyond 48 hours, most probably he will have permanent damage to the penis and will be permanently erect. And I'm emphasizing this because we see the story, it's very sad. First 24 hours, the patient admires the erection. Next 24 hours, the family physician is giving analgesics. Then for the third day, the general surgeon is admiring. And by the time he comes to the urologist, it's gone. So it's an absolute emergency. It is a big medical legal problem, but the ones I have seen, the men have looked very sad, but they've not sued their doctor. They're good. I mean, a sonologist who's done a penile color Doppler, produced a priapism, did not advise the patient, didn't have it treated, could be sued, I would expect, for huge amounts. We try and tell the patient this happens, it was bad luck, you should have contacted the doctor early and soothed them down.
Sir, a person or a patient coming with a frequent night falls or frequent masturbation, how do you approach?
So, frequent night falls is typically a man who's not sexually active young boy. Main thing is to reassure him that it doesn't matter. But some of them get very disturbed by that. In that case, I will either use some drug that reduces emission like clomipramine, or you can even give an alpha blocker. This is temporary, but it stops it from coming out and helps his mind to settle down. But you need counseling also in addition to medication. One thing you should not give is any hormonal manipulation that will harm the patient.
2 or 3.
Masturbation, frequent masturbation, again, usually it's a 17, 18-year-old boy. I tell them that first of all it's not harmful, it's natural. If you've been married, you've been having sex frequently. But now that you're doing it, don't let it become obsessive. Don't worry about doing it, but divert your attention, go to the gym, do other things so that your energy is distributed. So you don't make him feel he's doing something wrong, don't make him feel guilty. Remove his doubts that masturbation will cause him to become weak or impotent or lose his semen, but at the same time divert his energy so it doesn't become obsessive behavior. But that reminds me, a very major problem we are seeing nowadays is porn addiction, because with masturbation is porn. And I have a lot of young men now who have erectile dysfunction with a partner because they're so used to hardcore porn that with a real life person they don't feel aroused. So when I get these patients, I warn them strictly that they have to stop watching porn. They can use fantasy in their head, but if they get accustomed to visually erotic material of high intensity, a lot of them have problems with real partners.
We have 3 more important topics to cover, so I'll request you not to give questions currently, and in the end we'll see how much time we have. Premature ejaculation. Is there a solution?
So premature ejaculation is of 2 types. Primary, which means from the very beginning he has been having premature ejaculation, and secondary, where he was normal and then at some point in time premature ejaculation appeared. Secondary premature ejaculation has a cause. Often it is prostatitis. Sometimes it is a period of stress which is now made him very anxious. So looking into these aspects, sometimes it's a thyroid disorder. Looking into these aspects may correct the premature ejaculation. And one person who got cured just with one phrase, I told him, remember to smell the coffee while you're having sex. And that just got him to slow down and relax, and the problem got solved. Many of them you treat the prostatitis and it settles down, and some secondary premature ejaculation is actually because they have ED. They need more stimulation to get the erection, and by the time they are ready, they also ejaculate. So such men, if you actually give them a PD5 inhibitor for the erectile dysfunction, cures both the ED and the PE. The vast majority of men, however, have primary premature ejaculation. They become soon after marriage, they become 10 years after marriage, but they tell you, doc, since the beginning it was a problem. Now somehow, somewhere he's read, his wife has read, they've become aware of it, but it was there from the beginning. A lot of evidence suggests that primary PE is actually biological. There is familial history, history between twins, even parental history, and it seems that there is even a genetic basis related to the serotonin receptors in the brain. So for men with primary PE, sex therapy may help, but more often they need medical therapy, which is based on modulation of the serotonin levels in their brain, because the primary etiology is a serotonin imbalance. So with primary PE, we will combine various forms of treatment. We will give SSRIs, serotonin reuptake inhibitors. We will also use psychosexual counseling to sensitize them so that they learn control. If they have an oversensitive glands, we will use sprays to anesthetize the glands partially. And if they have concomitant ED because of anxiety caused by the PE, we may also use a PD5 inhibitor. So it's a complex thing. What can you do at a primary level? The only drug officially sanctioned for PE is naproxetine. It comes as a 30 milligram tablet or capsule, and it is to be taken 1 hour before sex. 30 mg, the efficacy is quite poor. Most men need 60 mg. Even with 60 mg, the efficacy is only in about 50% of men. So a large number of men may not respond, but it's the first line, quite safe. The only significant side effect tends to be acidity. Sometimes we will combine naproxetine with PD5 inhibitors when the likelihood of acidity is even greater. So when I combine it, I will usually give them an antacid with it. Now if naproxetine doesn't work, or a patient is having very frequent intercourse, so naproxetine is on demand. Naproxetine is not for daily dosing because the onset is within 1 hour and the duration is only 6 hours. So they take it on demand. It's a short-acting SSRI developed specifically to treat premature ejaculation. But it is less effective than the long-acting SSRIs. So if dapagliflozin doesn't work, you then switch to the long-acting drugs, where your most effective drug is paroxetine, but my choice is clomipramine, which is a tricyclic antidepressant with SSRI activity, because clomipramine is much cheaper and has fewer side effects related to SSRI withdrawal. So in literature, clomipramine is used in the dose of 25 mg, 4 to 6 hours before intercourse. So when I started giving clomipramine, I gave it in 25 mg, and no man had premature ejaculation, because they all fell asleep before they could cry cells. So then I reduced the dose to 5 mg and 10 mg, and with that, 50 to 60% of men had control and they didn't fall asleep. So the main side effect of clomipramine could be drowsiness. Some men say, I feel a little weird or hazed out. Some men have either constipation or diarrhea. So I start with clomipramine daily dosing in the evening, roughly 5 to 6 hours before intercourse. Start with a very low dose, half a tablet of 10 mg, and every 10 days build it up. That way the likelihood of side effect is less, and you keep on increasing the dose till they have efficacy. Then continue that dose for some time while they are taking the tablet and they have good control. Then we teach them other psychosexual strategies like stop, go, and becoming aware of arousal levels, which I can't explain today, we don't have enough time, but you can read about it on the net, stop, go technique. And if with the clomipramine they get benefit, but without the clomipramine they don't have benefit, then many of them can switch to on-demand dosing. And I have a number of men who will take this 1 tablet or 2 tablets of clomipramine on the day of expected intercourse, and they have good control and they're happy with that. Another scenario you may encounter is a newly married couple. The guy comes to you and says, Doc, he got married, I'm having sex, but my wife is complaining that I ejaculate too quickly. This is a couple who's having sex maybe daily or 5 times a week. So that's a couple who will do well with daily clomipramine. And I have many of these men who are on 5 mg tadalafil and 10 mg clomipramine every evening at 5 p.m. Their sex life is great. Once they gain confidence and experience, then we start tapering the dose and teaching them strategies for naturally prolonging. And by then they've got the confidence so that they don't need the tadalafil. Then there are some men who don't respond to clomipramine, and then we put on paroxetine in gradually increasing doses, 12.5 mg in the morning, then increase it to 25, then 37, and slowly increase the dose, and all of them never to stop the drug suddenly, because SSRI withdrawal can be a major problem, and if you want to stop it, we will again reduce it, lower dose, alternate day, and then slowly reduce the drug. So that's why I use SSRIs as my third line. For those patients who complain that, Doc, the moment my penis touches the vagina, I ejaculate, very sensitive, some of them we can use a spray. Currently we use a 10% lignocaine spray, which the anesthetists use. So it's available only in pharmacies of large hospitals. But within the next few weeks, Cipla is going to use a new spray, which is licensed only for this purpose, which is a mixture of lignocaine and prelocaine. And the benefit of it is that it gives a metered dose. So one squeeze will give a measured amount of the anesthetic. They recommend 3 squeezes 5 minutes before sexual activity to be applied to the glands, and then it can be left there or wiped off. And that will be useful for men who are either having sex for 1 or 2 minutes and want to prolong it further, or who have very sensitive glands. But if it is more in the brain related to serotonin, then they would need the medication.
Okay. There are combinations of dapagliflozin, tadalafil, probably dapagliflozin, sildenafil. You would use them separately or you would use them together?
So dapagliflozin, tadalafil is a bad combination.
Bad combination, okay.
Why? Because the pharmacokinetics are different. Peak onset of tadalafil after 2 hours, duration of action 36 hours. Dapagliflozin peak onset in 1 hour, duration of action 6 hours. So dapagliflozin is better combined with sildenafil, which has a similar pharmacokinetic action.
Our next topic is male infertility. First of all, etiology. what should the family physician look for when a couple comes with infertility in the male?
So that's a very important question, etiology, but I'll take a step back and I'll talk of preventive etiologies. As a family physician, what should you watch out for in the young child and adolescent to prevent them from becoming infertile in future? So first of all pediatricians should be doing it, but you can cross-verify that male child, make sure the testes are down. And sometimes they may be down at birth and then retract up. So whenever the child comes to you, just make sure the testes are where they should be. Because the current thinking is that if the testes is undescended, it needs to be operated within the ages of 6 to 12 months to preserve fertility optimally. And if that is missed, that is a major tragedy. So look out for that. Second thing is, if there is a torsion, sudden pain in the testes in a child, it is an absolute emergency. So any sudden onset of pain, drop everything, get the sonologist to do a quick ultrasound, and if there is a torsion, I pressed the button, I got so excited. So in the old days, before ultrasound was available, my father tells me the victim was pain. There are two ways of treating this. One is to change the battery, second is to put in a sildenafil tablet. We have neither available. In the old days, the victim was any scrotal pain explode because it's such an emergency. Now, of course, ultrasound is available in every nook and cranny. The moment there is pain, do not wait for anything. Must do the ultrasound, and if there is a torsion, immediate surgery, and very important, the opposite testes also should be fixed. We've seen tragedies where one testis was lost, opposite side not fixed, and 5 years later the other side also twisted. So that's something to be aware of very practically. Third, mumps orchitis. A lot of children will get mumps, majority will not get orchitis, so then it doesn't matter. But if there is orchitis, consult someone. There is evidence that giving alpha interferon will reduce the likelihood impact of the mumps orchitis on future fertility. So these are a few things. And lastly, varicocele. Now varicocele is tricky. Do not refer a child for ultrasound to look for a varicocele, because those mild varicoceles don't matter. But if while you're examining the child there's a varicocele that is obvious to you, a big varicocele, then have someone monitor it. A lot of adolescent varicoceles do not need treatment, but if the testes where there is a large varicocele is small and remaining small over a period of observation, then correcting that varicocele may help preserve future fertility. So these are some prophylactic things which as a family physician you can look for and take care of to prevent infertility in future. Then when a male comes to you, doc, we've been married, or the wife comes or the couple comes, that it's been 6 months, nowadays they come at 3 months. It's been 3 months, she's not got pregnant, what should we do? Definition of infertility is trying for 1 year before you even label them as infertile. But we live in an era of instant coffee and now in an era of Instagram where attention spans are 2 minutes and patience is not a word that is heard of. So couples will come to you at any time and they'll ask you, doc, what can we do? So don't push them off. Basic evaluation for the male is semen test, for the wife and ovulation profile. The only danger of doing a semen test too early is that very often the semen is borderline, which doesn't mean anything. The couple may very easily achieve pregnancy, but once they see that report, they go into a hyper mode and 2 months later at the age of 25 they want to do IVF, which is absolutely ridiculous. So a couple of important points which I'd like you to carry home so that you can counsel the patients, because as a family physician, you're the trusted advisor. Remember that young couples will very often achieve pregnancy irrespective of the sperm count. So just because count is a little low, it's not a cause of panic. In fact, semen parameters are only about 50-60% predictive of fertility. And there is no clear cutoff. The The WHO publishes a manual of semen analysis. So whenever you see a semen report, there will be the values and there will be the WHO parameters. The 6th edition has just been published few months ago, and in the 6th edition, and this is radical, they have removed the cutoff reference value. There is no value given in the manual saying that below this value is abnormal and above this value is normal. Because they recognize that there is a huge overlap between fertile values and infertile values. A couple may achieve a pregnancy at a count of 5 million, may not achieve a pregnancy at a count of 50 million. And therefore, you look at the semen report, and of course if it's on the lower side, one may seek to do something, but equally important, the age of the couple, the age of the wife especially, the duration of infertility become very important. So if I have a couple who are in their early 20s, 23, 25, married since 1 year, trying for a child since 6 months, whatever the sperm count, I would not go into a panic, and more than 30% of them will achieve pregnancy even with a count of 5 million and 10 million. Many gynecologists don't know this. Therefore, you should know this so that you stop the patient from going into a panic. Pathologists are terrible. I've seen semen reports where normal count is mentioned as 60 to 150 million. Those are reference values from 1990, which have not been changed. The previous edition, which was 10 years ago, gave a reference value of 15 million per ml, or a total count of 40 million. The latest has removed even that reference value. On the other hand, if a couple is 35 years old, married since 10 years, even if the semen parameters look normal, this is a couple where I will be telling them that if nothing has happened naturally, there is probably some physiological defect somewhere, which the routine semen parameters are not showing, and you need to consider IVF. So age of the couple and duration of infertility may be even more important than the semen analysis. So do look at it as a rough ballpark figure, count less than 15 million per ml or 40 million total, or motility less than 40% should be a cause for worry. Very important point to remember is morphology. As per the 5th edition of the WHO, more than 4% normal form is normal. In other words, a patient could have 95% abnormal sperm, and that is still a normal semen report. Very important to know this, because enough patients come to me, "Doc, will we have a two-headed baby?" What has happened is that the criteria for morphology have become very strict. So that even fertile samples are being marked as 3% normal, 2% normal. So much so that now there are many published papers that even with 1% normal form and 2% normal form, pregnancy rates are the same as those with normal morphology. So if you have a semen report from an IVF lab that says 4% normal, don't panic and don't let your patient panic. It is just that the teacher in the classroom has become over strict, and if the teacher is too strict, the test loses discriminatory ability. So that is what has happened. So very important, reassure your patients that don't worry about morphology. We're not going to have a baby that looks like a monkey. Nor is this 95% abnormal sperm count because of your infertility.
May I go back one step? Varicocele, when a couple comes with infertility and the male is examined and found to have varicocele, what is the chance that varicocele is the cause and should be operated?
Very important question, but again I'll take a step back. Based on what I see practically, male comes with a semen sample that looks subnormal. Without examination, people send him for an ultrasound to look for varicocele, which is the usual practice because most people don't examine the male. And that is an absolutely incorrect thing to do. Because correction of a subclinical varicocele is of no value. By subclinical we mean that if an experienced surgeon or urologist examines the patient and does not find a varicocele, then even if the friendly neighborhood Spider-Man sonologist finds a varicocele, which they usually do, some grade or the other, that is of no significance. So if you send for ultrasound before an examination, that is putting the cart before the horse, because that ultrasound report has no value until the patient is examined. So it is much better to have the patient examined, and only if there is a clinical varicocele, then it may be confirmed by an ultrasound if surgery is being planned. Because then we come to your question, that should every clinical varicocele be treated? So subclinical should not be treated. Should every clinical varicocele be treated? So again, there are grades of varicocele. Grade 1 varicocele is just a little bit of fullness and only a little bit of reflux if you've done the Doppler ultrasound. And generally the improvement with such varicoceles being corrected is not very significant. Larger varicoceles, which are easier to detect, more obvious, 70% of the couple or of the men will have significant benefit. So still 70% is 2 out of 3, and that should be the counseling. So if the couple is young, trying time is short, even if there's a varicocele, if the semen parameters are borderline, you can give them conservative therapy, antioxidants, lifestyle change, and 25% of them will achieve a pregnancy without correcting the varicocele, and the varicocele can remain lifelong because it has no other consequence. This is a common question they ask, Doc, okay, forget fertility, but if I get pregnant and we don't correct the varicocele, will it harm my husband in any other way? It has no other impact. The majority of varicoceles do not need surgery and do not do any harm through a lifetime. Some varicoceles, and why some are bad and some are good, we don't understand. Some varicoceles will cause the testes to become small, may cause it to become soft, may cause hypogonadism, may affect sperm count, and correcting it may produce a dramatic improvement, but not all. So, bottom line take-home message, first, don't do an ultrasound for every case to look for varicocele, because that will leave you confused. Ultrasound will show varicocele, now you and your patient don't know what to do because there's no clinical correlation. First step is a clinical examination. And unfortunately, a lot of surgeons will write clinically normal, refer for ultrasound, which means you need to change your surgeon, because that's wrong. If clinically the patient is normal, he doesn't need the ultrasound. 2, if there's a clinical varicocele, couple is young, initially give a trial for 3 to 6 months. And if there's no improvement in semen parameters, no pregnancy, then they may consider varicocele surgery. Couple who has already been trying for 2-3 years, has already taken medication, now comes to you, Doc, I had this ultrasound done last year, there was a varicocele, we didn't get operated, but nothing has happened, should I get operated? Yes, there is a 60% chance that you may benefit significantly from surgery.
Sir, can you tell us about, sir, can you tell us about Klinefelter syndrome? And because we are told that 1 in 600 is the incidence of Klinefelter.
Very common.
So what, we have almost, none of us have ever diagnosed on our own Klinefelter, almost all of us.
So we see it quite commonly. Klinefelter's 47XXY and variants thereof. Recently we had one 48XXXY. So most Klinefelters will present with azoospermia. Few of them have extreme oligozoospermia. Some of them will have normal puberty and will present as infertility. Some of them will have incomplete puberty and will present as a late teenager, saying that there is not enough hair growth. So the management varies. You have a Klinefelter, you have a young boy coming at 17, 18, parents bring him, Doc, he's not still looking like his other brothers, he's not got enough hair. You examine him and testes are really tiny, maybe a little gynecomastia, typically should be tall but sometimes maybe more obese. These are patients where you will get a hormone analysis done, FSH will be very high and testosterone will be very low. Then you get a karyotype done and it's 47XXY. Ideally such a patient should be managed by either an endocrinologist or an andrologist, because they will need lifetime endocrine support. But the treatment they will need at that point is testosterone to achieve androgenization. The second presentation of Klinefelter will be got married, 2 years or over, finally got a semen test, azoospermic. They show you the report. If you examine him and you find testes are very small, or if you don't examine him, but azoospermia, the least you can do is get his FSH testosterone done. And you do that for the azoospermic male, and FSH-LH are very high, testosterone is very low. That means this is a case of testicular failure. Again, this is a man who ideally needs to be seen by a specialist because the management is highly specialized. Now, if a man has Klinefelter syndrome, he has tiny testes, this small. In the past, we told them there is no treatment option. Now, what is interesting is roughly 1 out of 4 men with Klinefelter syndrome, tiny testes, genetic defect, high FSH, low testosterone. When we cut open the testes and look inside, we find somewhere an area that contains sperm. So this procedure is called microdissection TSE. TSE is testicular sperm extraction. Microdissection is because we cut it open and under a microscope, 20 times magnification, spread out all the tissue. Most of it will be jelly-like, and through that we are hunting for something that looks like a tubule. And it's possible if you find the tubule, it doesn't happen frequently, 1 in 4 cases, you find the tubule, you find sperm. Surprisingly, if you find sperm, most of these sperm tend to be chromosomally normal.
Wow.
And if they are used for IVF, ICSI can produce a healthy baby. So in the past, when you found sperm, we would tell them that you do IVF, then we will do pre-implantation genetic diagnosis, PGD. But now there have been many studies where even without PGD, the offspring have been born and they were normal. So Klinefelter has 2 issues. One is androgenization, which may be at puberty or later on as they grow into adults, because they are prone to hypogonadism, and 2 is fertility.
Wow, that is exciting. Next we come to is...
Somebody had a question. Sorry.
Sir, what is the clinically significant varicocele? How can
So
we
clinically significant varicocele is one where it's palpable tortuosity. And then if you're doing a Doppler ultrasound which shows significant reflux on respiration or mild valsalva.
We can tell you how to examine the scrotum or the area. Just very basic palpation.
Yeah.
How to palpate.
So if you examine the patient and if the patient is embarrassed, you're embarrassed, what you can do is have a small paper napkin, cover the phallus, push it to one side, then examine the testes. That makes them feel more comfortable. And then you can see the patient first lying down, so feel the testes, sides, try to feel the epididymis, vas, cord, then make them stand up, or at least see them standing. And when they are standing for some time, if there's a varicocele, you'll actually see like a bunch of veins. And if you feel, you will feel like typically what is called as bag of worms, but you will feel like dilated cords. There may be a mild varicocele which you might miss, which is okay. But if there's an obvious varicocele which you can pick up, that itself is a significant varicocele.
and cough? With the cough we get an impulse.
Cough impulse is a very tricky one because the cremaster also contracts. If there's a cough impulse, you may write there varicocele query and consider referral to a specialist if your conventional therapy hasn't worked. Because only a cough impulse is an early varicocele and the treatment is certainly not a matter of urgency. So that could be noted, but it doesn't demand immediate action. I'll come to there, yeah.
Any role of prolactin levels?
So in azoospermia, any role of prolactin, very good question. Now, whenever a gynecologist sends me a patient, the patient has FSH-LH prolactin level, which is wrong for the male. For the male, we want FSH-LH testosterone. Prolactin is very little relevance to male fertility, more relevant to sexual dysfunction. So if you have to do it in the male, it is FSH, LH, or FSH alone and testosterone, not prolactin. It's a very important point. And if the patient is obese, then we also look at estradiol, because in obese women the testosterone gets converted to estradiol, and if that is the case, then we may give an aromatase inhibitor. Question behind? Somebody?
How do you grade the varicocele on ultrasound?
So in ultrasound, we grade it 2 ways. If you're looking at ultrasound, you can look at the diameter of the vein. More than 3 millimeters is significant, and then 3 to 3.5 or more than that. What I prefer instead is a Doppler grading, which is how much reflux is there and with what stimulation. So the most severe varicocele is one when the patient is just standing. Not even breathing deeply, but you can detect or hear the reflux. Slightly milder than that is where on quiet respiration you hear reflux. Milder than that is when they blow gently, then you hear the reflux. And mild varicocele is only when they huff and puff like the big bad wolf, then you get some reflux. And what causes them to reflux?
The next question, within infertility, there are reports that lifestyle, especially contaminants, plastic, phthalates, etc., have decreased sperm count. Is it relevant? And
It's relevant but not actionable in a major way, because definitely fertility has gone down. There are many lay papers and medical papers on the decreasing sperm count, and the ones who write dramatic papers write the title Vanishing Male. Now they don't want to read about it. So yes, sperm counts are going down, and there are many studies showing that this is because of the endocrine disruptors in the environment, which are pesticides. DDT is a very well-known one, and a lot of the plastics and certain other chemicals. If you want to read a really scary book, there's a book called Our Stolen Future. Amazing documentation of how pollutants created by man have affected fertility across all species. Not only humans, but even polar bears up in the North Pole have reduced fertility due to the chemicals that we are releasing. Some practical applications. One is if a male is trying for fertility, they need to minimize the use of plastic in their day-to-day use. So standard thing, the sandwich that you get from a restaurant wrapped in that plastic stretch. Studies have shown that chemicals from that plastic stretch leach into the bread, and they can act as endocrine disruptors. Sometimes they get a wife with their husband. Don't tell me what should I feed him. So I tell her, feed him only organic food. So then she feels she's really doing something, and maybe it actually helps because it's eliminating the pesticides. Sometimes the mother-in-law said, 4 glass doodh piyo. And I tell them, stop dairy. Because too often in the dairy farms they are injecting hormones, estrogens and antibiotics to produce more milk. And that is getting into the milk and affecting them.
Oxytocin they are using. Oxytocin they are using
Oxytocin.
for the milk.
Yeah. For the milk and also hormones, estrogens. That is the same reason why I tell them not to use whey protein, because a lot of men come muscle building. I tell them don't use whey protein, get it from natural food or get plant-based protein, because whey protein is purely industrial milk, where almost inevitably the cows are being injected with hormones because you need huge amounts of milk to produce the whey. Related to that, in the gym, many of them take pre-workout supplements. On paper they are safe, they have creatine and this and that, but it's possible that many of them have some androgen added to add to the effects. I tell them no pre-workout supplement. And you need to warn your patients if they're coming to you that, and if he's looking really fit, are you taking hormones? Because now in gyms, giving testosterone is routine.
wow, okay.
Very routine. Or if you say, wow, that means you are cut off from the world. No, terrible. They have testosterone camps.
I thought there were more other androgens.
No, in every form of androgen, including testosterone. And they'll tell you proudly, oh doc, I cycle, and their cycling is even more sophisticated than the andrologist can do. So very common nowadays in the gym, because they have all these muscular bodies. Every transformation you read about in Bombay Times, you can be sure that despite his denial, he's taken hormones. You need those androgens to make that muscle. And these young boys see that, and a lot of them take it therefore. So warn them that if you're trying for a child, make sure, and he looks fit and he's going to the gym, no sauna, no steam, no androgens, no supplements, no whey protein. Plant-based proteins are available where proteins are got from peas and many other sources. You can buy it online. Online it's available and much safer. Soya is tricky for men because soya has an estrogenic action. So soya can be taken in very limited quantities, and especially young men trying for fertility should not take soya. The other plant-based, there are many other sources, peas being a very important one, but beet and many others. These are now freely available. Exercise very important, and on this, one very important thing I tell patients, because this is amazing evidence that has come. A study which was done where they took monogenic rats. Half of them were given a good diet, half of them were given a diabetes-inducing diet. They're monogenic. Then they were allowed to reproduce. The offspring of the rats that were fed a diabetic diet were more prone to diabetes and other metabolic problems. We always say that the health of the mother will affect the offspring, but now there is evidence that the health of the father at the time of conception through epigenetic modification can actually modulate the sperm genes and affect the health of the offspring. So all my patients, I tell them the best gift you want to give your child is to be in optimal physical health at the time you are planning conception. And this is one piece of advice you can always give your young couples, because they're going to chat with you or you know they got married. This is advice you can give them, that stay fit, avoid smoking. Cell phones, people often ask me what to do, we'll talk about that, but exercise regularly, eat healthy, and if they are healthy, the sperm quality is likely to be better, and the health of the offspring is likely to be better. Very important.
Of the antioxidants, CoQ10 helps in...
What medications do you give for infertility?
So what medication including this? Again, a useful question. Now, first, what medications can you give? Studies have shown that if empirically you look at antioxidant use in a huge population, giving antioxidants increases the chance of pregnancy. Having said that, excessive antioxidants can cause reductive stress, which is the opposite of oxidative stress, and can actually be harmful. So giving too much is not good. Sometimes I see prescriptions where 3, 4, 5 antioxidants are written, they may do more harm than good. Also remember that these combinations with CoQ, carnitine, etc. are quite expensive and can easily cost the patient more than 100 rupees a day. And many of the patients are poor, they cannot afford it. Some of them come with a prescription, no doc, after a month we stopped, it was too expensive. There is no evidence to show that CoQ is superior to a 3 rupee or 4 rupee lycopene or vitamin E. So how do I treat patients? All patients from lower socioeconomic class, I give them a combination of multivitamin, lycopene and vitamin E. Combined cost should not be more than 10 rupees a day. And surprisingly, many of them come with improvement, possibly because they were genuinely nutritionally deficient. For those patients who can afford it, you give one of these combinations. None is superior to the other, but be careful, don't overdo the dose. Don't think that I'll give 4 different brands and he will improve faster. Give any one. Who is sponsoring today's Sorry, no sponsor, no. There is honestly no, they're all the same.
Promethazine citrate 25 milligrams.
We'll come to that. No, antioxidants, the treatments you're asking for are combination of coenzyme, levocarnitine, lycopene, selenium, zinc, all of that in there. And they're all roughly the same, irrespective of what the person tells you. Now the next question was clomiphene. The broader question there is hormonal therapy for male infertility. Should not be given empirically. So don't just write clomiphene for any male. And sometimes I see these. You have to look at the hormone profile. So if the sperm count is more than 10 million, no hormone therapy is indicated. If the sperm count is less than 10 million, you look at FSH, testosterone. If testosterone is over 400, that means that he is already adequately hormonally stimulated. That is why he is making enough testosterone, and you don't give any hormone therapy. No clomiphene, no tamoxifen, no injections, nothing. If testosterone is low, that means the testes is not fully stimulated, then you look at FSH and LH. If FSH and LH are very high and testosterone is low, that is a case of testicular failure, because already he has high gonadotropins, but the testes is not responding. Giving such a man clomiphene or HCG, HMG will not help. If testosterone is low and FSH/LH are mid-range, then maybe there is scope for stimulating this testes, and there you could give clomiphene 25 mg daily or tamoxifen 10 mg twice a day. The reason why I don't give tamoxifen is the label says for CA breast, so patients get very anxious. If the patient is obese, we will give an aromatase inhibitor like anastrozole 1 mg alternate days. So that will reduce estradiol, raise testosterone, and by reducing estradiol, it will affect the feedback loop and raise FSH/LH. And then there are gonadotropins, HCG, HMG, which I think you should not venture into because they're expensive, tedious. Clomiphene will do the job where required. But give clomiphene or any other hormone therapy only if gonadotropins are mid-range normal and testosterone is on the lower side, not to everybody. Never ever give what? Never ever give injectable testosterone. If testosterone is low, FSH/LH is mid-range, never ever give injectable testosterone. If you give injectable testosterone, whatever sperm he has will disappear. Because when you give testosterone, FSH/LH will get suppressed and spermatogenesis will stop. Oral testosterone in the form of Masturbation, brand name is Provironum, does not cause the suppression and may be used, but injectable testosterone never. If testosterone is low in a man with infertility, the treatment is with clomiphene or anastrozole or letrozole, but not with injectable testosterone.
So regarding this hormone abuse, now we have this young boys, they are using basically stamazole, and then they are using even growth hormone they are getting in this thing. What do you do in such patient if you encounter such? Growth hormone also is being used extensively.
Who uses it? Bodybuilders.
Yes.
Bodybuilders use crazy things. If they want to try for fertility, they have to stop everything. And after they stop everything, you have to do their hormone profile. And sometimes they've been very good in their cycling and the hormones are not affected and seen as normal. But you have a bodybuilder who's azoospermic. Then you have 3 or 4 options. One option is stop everything, wait and watch, and naturally FSH/LH may come up and sperm production may start. This will work if they've been on androgens, etc. for a short period of time. If they've been taking for a long period of time, waiting will not help. You may need to start them on HCG, HMG right away or clomiphene. And sometimes if they've had it for a very long time, whatever you do, the testes remain small and they remain azoospermic. So I've seen all 3 things happening.
Sir, hyperprolactinemia in males and its contribution to infertility.
Hyperprolactinemia in males is usually not a cause of infertility. Most men, when you do their prolactin, you will find it to be 30, 35, which is significant in women, it is of no significance in men. That mild elevation is usually stress-induced. Women tend to have microadenomas, therefore the prolactin goes up to 50, 40, and they are given medication. Men, when they have a significant problem, usually have macroadenomas, and their prolactin is in hundreds and thousands. So mild elevation of prolactin, even if you treat it, you will not see significant benefit.
And sir, their correlation with gynecomastia in men?
So when will you look for prolactin in a male? Gynecomastia, milk secretion from the nipple, concomitant low libido in ED, yes. But a male coming purely for infertility with none of those symptoms, don't even do the prolactin. So that's an important message because too often prolactin is done, found to be marginally elevated and unnecessary treatment given.
So again it will be testing for prolactin only when we see the clinical signs for a
only when you see something suggestive.
For the last half an hour, we have another important topic, which is andropause or late onset hypogonadism. So first, andropause, terminology wise, some comments.
So we'll try and cover this quickly, so there's some time left for question answers. So basically you had menopause, and therefore the term came andropause, and for many years the articles used to be written andropause, myth or reality. And the reason why this confusion arose is when you say menopause and andropause, you try to equate them. Menopause happens in a definite age range with very obvious clinical symptoms, with very measurable hormonal changes. In men, no such thing happens. There is no fixed range in which testosterone plummets and symptoms appear. There is a certain proportion of men who never reach andropause. And those who do enter andropause can do so at a varying age range, anywhere from 60 to 80 years, and sometimes earlier if they are prone to it. So there's a very wide range of age with a very wide range of symptoms during which men reach a low level of testosterone which may need treatment. So what happens in men is from the age of 30, testosterone production starts going down. SHBG, which is the sex hormone binding globulin, starts to go up. It's a very gradual fall and a gradual rise. So when SHBG goes up and total testosterone goes down, free testosterone, which is the testosterone which is not bound to the sex hormone binding globulin, because in circulation, the total testosterone which is present, 60% of it is bound to globulin, is not available for any biological activity. 38% is bound to albumin, that is easily released and is available. 2% is bound to nothing, is free testosterone and is available. So bioactive testosterone is the free testosterone plus the albumin bound testosterone. So as a man ages, total testosterone is going down, sex hormone binding globulin is going up. Therefore the free testosterone is dropping more severely. At some point in time, that free testosterone reaches a critical point where now the lower levels of testosterone start manifesting with symptoms. But the problem is the time at which this happens is very variable. Doesn't happen in everybody, and the symptoms are very variable, and the symptoms that appear are equally attributable to the normal age-related symptoms. And that is why there is so much confusion. So there is no single symptom that is diagnostic of andropause. So a cluster of symptoms that you will look at is reduction in morning erections, low libido, low energy, general tiredness, falling asleep during a lecture. Anybody?
Not here.
In fact, in our lectures on andropause, everybody who falls asleep, there's an assistant who goes and gives them a shot of testosterone. So once I was giving this talk in Varanasi, and at the end of it, a psychiatrist came up to me and says, Doc Shah, you know, I'll tell you a story. That I was someone who could remember patient's name, occupation, residence, everything. And then there came a time when I could remember nothing. And finally they found that my testosterone was low, and when it was corrected, now I'm back to who I was. So there are patients who will come and tell you, Doc, I feel like a new person after taking testosterone, but these are very few. So is my take-home message, check everybody for testosterone? No. Give everybody testosterone? No. But just be aware that if you have someone in their 60s or 60 plus who is complaining of a lot of tiredness, lack of libido, generalized loss of memory, again, most probably it is not due to the low testosterone. It could be his wife nagging him most often. But you could get his testosterone checked, and if it is low, then you repeat the testosterone in combination with FSH-LH prolactin, and then you will decide to give him a trial of testosterone replacement. And if after 3 months of testosterone replacement, he feels much, much better, he says, Doc, you're the best doctor in the world, then he's a man who could continue on testosterone therapy. You do need to monitor the PSA, because sometimes testosterone therapy may uncover a pre-existing prostate carcinoma. There used to be a big debate that will taking testosterone increase the risk of CA prostate. That has been laid to rest. Lots of studies showing that giving testosterone does not increase the risk of cancer prostate. But if somebody already has a cancer there, then giving testosterone may cause it to flare. So So when you put them on TRT after 3 to 6 months, you need to recheck the PSA, and if it has increased significantly, if it has doubled or gone up by more than 1 nanogram per ml, then you need to send them to a urologist.
It's the same as finasteride, dutasteride. They don't increase incidence of cancer, but can cause a more severe form.
Sorry?
When you check for free testosterone,
Okay, very good question. Ideally, you should be checking for free testosterone or bioavailable testosterone. However, the test for free testosterone involves reverse equilibrium dialysis, and the test for bioavailable testosterone involves a method called ammonium sulfate precipitation. Neither of the two methods are done by any of the labs in the country. All the labs do an RIA for free testosterone, which is notoriously non-reliable. And therefore, though free testosterone is more important, what you should look at is calculated free testosterone, which you get by measuring total testosterone, SHBG. You can measure albumin, or it is assumed to be 4 grams. So you measure these three, and if you go online and type free testosterone calculator, it will appear online. You feed in these values and you will get a calculated free testosterone, and that is more reliable than the radioamino acid that the labs will provide you in the country. So therefore we look at total testosterone. If it is more than 400, we consider it to be normal. If it is less than 200, we consider it to be abnormal. If it is in the gray zone, 200 to 400, that is where we will calculate the free testosterone and then decide whether he is hypogonadal.
I would like a recap of the term late onset hypogonadism in terms of symptoms and biochemical parameters, so that we again are told when to measure testosterone.
Sure.
If at all.
So the original term was andropause, then came the term ADAM, nice acronym, androgen deficiency in the aging male.
Wow.
Then they realized that it's not a severe deficiency, so ADAM became PADAM, partial androgen deficiency in the aging male. But for insurance reasons, they found that when they were talking of androgen deficiency, insurance was not covering it. This is in the West. But if it was termed hypogonadism, then the insurance cover was available. So andropause, ADAM, PADAM became late onset hypogonadism, which now is more medically acceptable and therefore covered by insurance. So that's how the term came about. So late onset obviously means we are not talking of the hypogonadism of a man with Klinefelters. We are talking of hypogonadism that is developed as a consequence of aging. So we are looking at hypogonadism in men over the age, you might say over the age of 40, but if you look at population studies, over the age of 60, 20% of men have hypogonadism. So looking at it below 60 is not very productive. Unless the male is prone to hypogonadism, so someone non-Klinefelter, somebody with testicular atrophy, somebody who had testicular torsion, who has small testes, they may develop hypogonadism in their 40s and 50s. Diabetics are more prone for an earlier onset of hypogonadism, otherwise in the routine population over 60. So late onset refers to therefore over 60 or over 40 if they are at risk. And in such men, again screening everybody doesn't make sense, but if in your casual medical history the symptoms come up, which we spoke about, then we will check first total testosterone only. Morning sample. Testosterone must always be in the morning between 8 and 10 because that's when it is at its peak and then it goes down. So testosterone measured in the afternoon or evening will be unreliable. So even though it may be inconvenient for the patient, it should be measured in the morning. One single report is often not reliable. So if the first report is normal, fine, but if the first report is abnormal, then after a couple of weeks at a different lab, recheck total testosterone together with FSH, prolactin, and then based on that reach a diagnosis and then proceed further. Immunosuppressed may be prone to hypogonadism. Again, it's based on the symptoms, why are they immunosuppressed? Sometimes their other medical conditions may be exhausting them so much that the testosterone may not be very significant. There are some studies suggesting that even patients with depression, immunosuppression, HIV and low energy levels, restoring testosterone may help their energy levels to some extent.
Liver failure,
Cystic fibrosis
Liver failure, see, all these people are very ill, and if you're giving testosterone again, it is metabolized by liver enzymes. So you could consider giving testosterone, but very cautiously. Cystic fibrosis doesn't affect testosterone.
Should we investigate all male osteoporotics for testosterone deficiency?
So currently the recommendation is that if a man has osteoporosis, but no other symptoms related to hypogonadism, it's better giving bisphosphonates or all the other things rather than testosterone. If somebody is hypogonadal, one of the reasons to give testosterone would be to prevent osteoporosis, but not the other way around. Because giving testosterone therapy involves more monitoring and is therefore more complex. So if the primary presenting symptom was osteoporosis, you need not look at testosterone.
Can you tell us about the basic testosterone formulations?
So testosterone formulations are 4 primary formulations available here. Patch, for example, is not available, pellet is not available. So you have the oral tablet testosterone undecolored, quite ineffective and expensive, so I would not recommend looking at it. Second is testosterone gel, quite convenient, well not convenient, but quite painless to use. Nowadays you get applicators, so you squeeze the bottle and each squeeze will give 125 mg. So 4 squeezes, after bath the patient applies it to the hairless area of the shoulders and upper chest, waits for it to dry, has to be very careful to wash his hands afterwards. Disadvantages: 1, daily application many people find inconvenient. 2, if they are not careful and don't wash their hands, they may transfer the testosterone to other family members, so they need to be careful. Third is short-acting testosterone, like Sustanon or Testosterone, which is given every 2 to 4 weeks depending on the requirement, which is quite effective, but it causes very sharp peaks and very low troughs. So the initial period of the therapy and the last period of therapy is not very good. Injectable Sustanon and Testosterone. And then there is injectable testosterone undecolored, which is a long-acting testosterone. Average duration of action is 3 months, and which gives a more uniform release. So in young men, sometimes we get men who have lost both their testes and will need lifelong testosterone. For them, usually I prefer testosterone undecolored. The only disadvantage is it's a little painful injection because it's oil-based 4-hour. And it has to be injected slowly. But the advantage is it's once every 10 to 12 weeks, so it's easy. For men with late onset hypogonadism, often what we will do is we will start with the gel every day. Because in case they have side effects, like mood changes or excessive snoring, or if the PSA is shot up, then immediately you can stop the gel. Whereas if you're given the injectable, there is no control over it. If with the gel they do well by 3 months, and if they're going to continue long term, then we can give them the choice to switch from gel to injection. Though some men say, doc, I don't want the gel, give me the injection. In that case, we may use the shorter acting product like Sustanon, once every 3 to 4 weeks, 3 injections, and then assess the outcome.
One topic that we forgot and we should discuss is sexual dysfunctions, ED for example, due to drugs which are used in medicine. For example, SSRIs themselves cause...
Sure. So many drugs can cause erectile dysfunction. SSRIs, which we use to treat premature ejaculation, may cause ED. And a lot of men with psychiatric problems who are on SSRIs may present with one of 2 problems. Sometimes ED, but sometimes the erection may be okay, but libido is low, so frequency is less. And often their problem is no, libido is there, erection is there, but there is severe delayed orgasm. they are not able to reach an orgasm because we're giving SSRIs to treat
Premature ejaculation.
premature ejaculation. A side effect is delayed orgasm, and you may encounter that in your clinic in a young male. He's 25, 30, schizophrenic, well controlled with his antipsychotics, now married, and they want to have a child and he's unable to ejaculate. That is a clinical scenario. So for these men, what we do is we ask them to stop the drug for 1 or 2 days, by which time the levels drop a little but not too much, and then we give them a penile vibrator, which is a massager that gives a strong stimulus to the penis for 10, 20, 30, 40 minutes, and half of them are able to reach an orgasm with that, and we collect the sample and use that for fertility. Then many of the antihypertensives are associated with ED, though very often it is not the antihypertensive, but the act of lowering the BP. So the penile vessel has become narrow. When the BP was high, there was enough pressure to fill the penis. When the BP is normalized, which is good for the heart, there is now not enough pressure pumping blood, and therefore the penis doesn't develop rigidity. So sometimes with the start of antihypertensive therapy, erectile dysfunction may develop, but you can't stop the antihypertensive, so you will combine it with a PDE5 inhibitor. Beta blockers, 20% of people on beta blockers are said to develop ED. So sometimes one may ask the cardiologist to switch from beta blocker to calcium channel blocker. So you were saying something about beta blockers.
Yeah, we have now, I think, enough like evidence that beta blockers do not, like you said, testosterone does not cause prostate cancer. Now we know that. Similarly, probably some studies have shown that beta blockers have more of a nocebo effect because people reading about it, or rather than any actual sexual dysfunction.
So one could give it a try, or not mess around if their BP is well controlled, and if they respond to a PDE5 inhibitor, that's a simple solution. Because the moment you change the antihypertensive, again you have to monitor, see whether it suits them, whether there are side effects. And often patients in that age group are having sex only once in a while. So if they do well with sildenafil without side effects, there's no harm giving that. Then some anti-androgens, spironolactone not used much now, and some of the estrogens or anti-androgens may cause erectile dysfunction. Alpha blockers, many men in the age group of 50 plus will be on alpha blockers, and often it will cause reduction in semen volume or absence of ejaculate. Often I counsel them that it's not a problem, even if the ejaculate reduces, you will still have erection, you will still have orgasm, you will still have pleasure. But some of them feel, no, the quality of orgasm has gone down, in which case it's often okay for them to skip the alpha blocker for a day or two. Their urine flow will slow a little, but it won't create a problem, but the semen volume will improve and the erection, the ejaculation will be better. And if they are prone to postural hypotension also, skipping one dose of the alpha blocker and then taking the PDE5 inhibitor may give them a better response.
Is bethanechol used? I don't know whether bethanechol is a drug used
Bethanechol is to cause bladder contraction.
not for premature, I mean not for low ejaculate.
Not for low
No,
ejaculate.
Muscle wasting. Can low testosterone cause muscle
Yeah,
wasting?
sure. So low testosterone, say for patient, one of the signs of late onset hypogonadism is reduction in grip strength or inability to play sports which you were playing earlier. So if a patient comes complaining of asthenia, weakness and tiredness and other symptoms, and testosterone is low, giving testosterone but also bringing an exercise program with it could definitely help the patient. So there have been several studies on use of testosterone in patients in old age homes to improve quality of life, improve self-care, and it could play a role. Very interesting study was done by Shores in the American VA group showing that irrespective of all other factors, those veterans who had low testosterone had a much higher mortality rate compared to those where testosterone was normal. So there could be more aspects to testosterone that we don't know. Many studies have shown that the insulin sensitivity improves, diabetic control improves, lipidemia control improves with restoring testosterone to normal. So that's an area that endocrinologists are exploring, but everybody is still proceeding with caution before advising routine testosterone to everybody. Sorry?
Any role of testosterone in females?
Again, not my subject, but low libido in postmenopausal women. So I'm not aware of studies explaining that, but it may help. The studies that I know about show very definite benefit from low dose testosterone when there are libido issues or arousal issues, especially in postmenopausal women. But maybe role for sarcopenia, but I don't know. About?
Epididymitis as a
Epididymitis.
cause of infertility.
Okay, so epididymitis, the diagnosis is essentially a clinical diagnosis, may be supported by evidence of infection in the urine or semen. We find several causes. One common cause often is filarial epididymitis or chlamydial. So very often my first line of empirical therapy is hetrazan or banoside in combination with doxycycline. If there's a known history of urinary tract infection or chronic prostatitis, then other antibiotics would be more useful. Some patients get recurrent epididymitis, especially people who have a voiding dysfunction, and in rare cases we have actually had to do a vasectomy to prevent reflux of urine causing recurrent epididymitis. In the infertile population, epididymitis you will find by a thickened epididymis, adherent epididymis, tenderness of the epididymis, and we will do urine culture, semen culture, give empirical antifilarial, antichlamydial, and further antibiotics based on the culture report.
Thanks. I think we'll end here, Dr. Devesh. No, he said that tadalafil depoxysteroid combination should not be used.
I said depoxiting daily is of no benefit. Daily dosing helps when a drug has a long half-life, so it has a cumulative effect. So that is true for the long-acting SSRIs. That is why daily dosing, and depoxetine is expensive. It will waste money, 50 rupees or so per tablet.
He's asking whether there is any
I don't use any of the
medication,
Ayurvedic medicines.
Shilajit and things like that.
But if patients ask me, can I take it? I tell them, sure. I know of one patient who had a priapism after being given some Unani medicine by a Hakim which involved crushed red ants.
Red ants.
So maybe there is something in these combinations that helps, but I have not studied them, I don't recommend them. Sperm freezing. Okay, again, very important take-home message. Thank you. Any of your patients, young patients in the childbearing age who has a malignancy for which they are going for treatment, remind them that they should freeze a semen sample. Luckily in Mumbai, all the oncosurgeons, oncologists are now sensitized, and I no longer see patients who have not frozen sperm. But as a family doctor, that is a very important message you can give them. Then sperm freezing for infertility, etc. is a whole different subject which the infertility specialist will advise. But this is very important message that no person should undergo chemotherapy without freezing a semen sample if he's in the age group of 20 to 40. Any cancer where they are going to require chemotherapy or radiotherapy to the pelvic area, because then we are faced with the tragedy of azoospermia later on, and then nothing that can be done.
Dr. Deepak, yeah.
Oh, we still do it, and I have enough mails from patients saying, Doc, I went to 4 IVF centers, they all told me only hope is IVF, and then we did their VA and they had a natural conception and they're very happy.
What is that? What anastomosis?
Okay, so what he's asking is if a man has obstructive azoospermia, due to a block in the epididymis. We can bypass the block by microsurgically joining the vase to the epididymis. 20 years ago, that was a very common surgery. In fact, that was the most common procedure I used to do. With the advent of IVF-ICSI, it became possible to just aspirate sperm from the testes with a needle and use those sperm to fertilize the egg. And therefore, the frequency of this surgery has gone down dramatically. So he wanted to know, is there a role? There is a role. IVF eventually has two problems. One, it is expensive and exhausting. Yesterday I had a man whose wife had about 20 eggs.
Wow.
Very, very low sperm count. They were able to fertilize 4 eggs. Wife is currently 3 months pregnant. So he was telling me, Doc, for the next pregnancy I want it to be natural. So I told him, why? There are 16 eggs lying there. All they have to do is fertilize it. She doesn't need any more hormones. He said, Doc, you don't know. After the embryo transfer, the progesterone that they give, the HCG that they give is so painful. I can see my wife in tears. I can't bear that pain anymore. So IVF is a major burden on the female partner. The IVF specialist has a tunnel vision, get them pregnant. But they don't see the totality. They don't see the male ego involved, who feels that I would like to impregnate my wife naturally. They don't see the couple sensitivity, that if we can achieve it naturally, so much better. They don't see that the pain the wife undergoes for a problem that was essentially a male problem. And for all these reasons, I think there is still a role for vasoepididymal anastomosis if the couple is young enough to have time for a natural pregnancy. On that happy note, I think we will end. I would like to thank you very much. It's been a wonderful audience. My pleasure.
A very small token from all of us, sir. Thank you so much, sir. Very, very glad that you came. Thank you. Thank you so much. We have a small contribution pouch there, if and when. Thank you.